Imagine a doctor working in a mobile clinic, a doctor unable to diagnose the cause of a fever. Why? Because the tests require fully equipped labs for accurate test results. Or consider a father who has to choose between selling his home and getting the life-saving hepatitis C treatment that he needs. Imagine a logistician struggling to keep vaccines cool and effective in blistering temperatures without electricity or refrigeration. In so many parts of the world today, people get sick and die needlessly because of hurdles like these and others like them. Seeing these gaps firsthand moved MSF to create what is now known as the Access Campaign.
In the late 1990s, the HIV/AIDS crisis was raging in developing countries, even though life-saving treatments were available in wealthy parts of the world. We were frustrated seeing our patients die from treatable diseases because they couldn't access the treatment they needed, or because sometimes they needed treatments that just didn't exist yet. So, in 1999, we launched the Access Campaign to speak out and advocate for access to medicines, vaccines, and diagnostics for the people we care for and beyond. Here is how we increased access to life-saving treatment over the past 20 years. We focused on prices. By encouraging the production of generic versions of life-saving drugs, we helped drive down prices. We worked to protect the space for more producers of affordable generic medicines. And we fought hard to challenge the high prices that exclude many children from accessing life-saving vaccines. We also had to tackle the problem of drug availability to make sure we can get treatments to the most neglected patients. For example, we worked hard to bring medicines back into production that pharma corporations had abandoned, and we collaborated with partners to increase access to life-saving tuberculosis treatments. And finally, we have always focused on the patient. We have been pushing for a research agenda that's focused on people's needs, not corporate profits. Lastly, we elevated patients' voices to put a face to these diseases and to drive change. Today, many new medicines, vaccines, and diagnostics are still too expensive. Many are not even being developed at all because pharmaceutical corporations still prioritize profits over lives. And today, the high price of medicines is still a global problem, not just a problem of developing countries. So we'll continue to demand change in this system to ensure access to affordable, effective, and life-saving medicines for all. 20 years on, our slogan is still as relevant as ever. Medicines shouldn't be a luxury.
This brings us to our second session of the day, how COVID has shaped justice and equity for access to treatment. This session will be moderated by Leena Mengani. Leena is the Global Intellectual Property Advisor and Regional Head of MSF's Access Campaign. Leena, I invite you and the panelists for your session onto the stage.
We really had a very good session in the morning with the opening remarks. So I'm just going to get down to business by introducing the panelists. This is, 20 years into the Access Campaign. This is 20 years into the time when MSF took the Nobel Peace Prize money and decided to set up the Access Campaign. And during that journey of 20 years, we've collaborated with a number of activists and experts. And some of them are here on the panel. And it's a beautiful journey for a lot of us who worked on access to medicines. So I'm going to start by introducing K.M. Gopakumar. He has a master's in intellectual property. He's a legal advisor for the Third World Network. For those who don't know Third World Network, they played a brilliant role in negotiations, in supporting negotiations from developing countries, particularly Malaysia, Latin America, many countries in Asia, and providing them with the technical support at the World Trade Organization and other forums to lead debates on access to medicines, and particularly commitments on access to medicines. So that's K.M. Gopakumar. And not many of you all know, but India's patent law, which was shaped in 2005, due to the amendments triggered by the World Trade Organization, many of those safeguards that we have today to protect generic competition come from individuals like Third World Network, from K.M. Gopakumar. So we really, please welcome him with a huge hand. Yeah. And we have Brynel D'Souza. Brynel is someone I bumped into during my work on HIV and gender. Bump is literally the word I would utilize, but since then we have kept in touch, and I would like to sort of introduce her. She's the chair of the Center for Health and Mental Health at the School of Social Work in Tata Institute of Social Sciences. One very important role that Brynel plays, besides being an academic, is the role she plays in the people's health movement. And even while she was sick with COVID, she filed an intervention on behalf of Jan Swasthya Abhiyan in the Supreme Court of India that helped universalize our access to the COVID vaccine. We got a very good decision thanks to the effort of the People's Health Movement led by Jan Swasthya Abhiyan in Maharashtra. So welcome, Brynel. And then, of course, we have Giten. I always have a problem pronouncing your last name, so I'm going to say Giten K. Okay, please forgive me. So Giten actually started his career in the Northeast when a large number of people were dying of AIDS. And he's been part of building capacity in Indian civil society to respond to not just HIV/AIDS, but viral hepatitis and other diseases that have impacted very vulnerable communities, including drug users. And now he's based in Bangkok, and he's the program manager at AMFA Street Asia, Southeast Asia response. AMFA, of course, many of you who have worked in HIV know, led a lot of the research and implementation on fighting AIDS in many of the countries that had a very high burden of HIV. So welcome, Giten. So this is the panel that we have. That's the exhibition we have. And many of the banners that you see were actually carried live in protests that we have held across the country. And we have, of course, Loon Gangte from the Delhi Network of Positive People. Delhi Network of Positive People has played a brilliant role in shaping civil society activism in the region and globally for access to medicine. So the exhibition is directly related to the panel. So I'm going to go directly to you, Brynel. Mr. P. Sainath from Pari mentioned about the whole issue of privatization of healthcare. And that was the going trend very strongly before COVID, that healthcare will be privatized in country after country. Has anything changed with COVID?
I don't think things have changed much, but we should have learned some lessons. Unfortunately, our memories are very short. I think, having been at the forefront of activism during the COVID pandemic and filed, having represented JSA Mumbai in a number of PILs, okay, on the regulation of the private sector, on price controls, on vaccines. What I would like to say at this point in time is that, for me and for many of us who have been part of the people's health movement and also academics and activists, we've seen how the COVID-19 pandemic has actually put a question mark on the private sector's efficiency in healthcare. Okay, we've also seen how profit-driven enterprises are ill-suited to protect the health and life of a vast variety of people. And one has seen this across the globe, and particularly from the US and the Indian experience. The COVID-19 pandemic should also serve as a wake-up call for all those who advocate the private sector's superiority over the public sector. In the context of the US, we've seen how the healthcare system, largely driven by private providers, both hospital and health insurance, spectacularly failed to protect the health of its citizens. Now, coming back to India, in fact, the US experience should concern us because India has been chasing the same model and something which Sainath has also alluded to since 1991, liberalization, cutting down public spending on health and promoting private care. We know as a country that our out-of-pocket expenditure is sky high, 3.4 times the global average. 63 million Indians are pushed into poverty every year due to catastrophic health expenditure. The average cost of hospitalization in the private sector is 6 to 8 times higher than government hospitals. And India perhaps is the only country in the world where even public health care incurs catastrophic expenditure. Now, and a lot of this is because the private health sector has been systematically neglected and underfunded over decades. And we've seen the dominance of the public sector has been systematically underfunded and neglected. And we've seen the dominance of the private sector. Now, but this public sector, okay, despite being extremely overwhelmed and strained from decades of neglect and underfunding, it still coped, or at least tried to cope. While the dominant private sector, okay, was on the fringe during this entire period. We saw that the private sector had actually retreated, closed shop, only to come back later to profiteer in a big way. What I wanted to basically say is that the second wave, in the context of the second wave, we saw a devastating crisis. We saw a shortage of beds, oxygen, ambulances, essentially the prices of drugs going up. But it was during this second wave, or immediately after the second wave had begun, when the country was grappling with a crisis that drew global attention, the Niti Aayog comes out with a report on investment opportunities in India's healthcare funding. So from the report, it's very clear that the Niti Aayog, amidst all this crisis, was looking at healthcare as an industry, okay, not as a public good, okay, and an industry ripe for investment, an industry which one needs to encourage greater FDI because there's already foreign direct investment, and was pushing for greater privatization, while at the same time acknowledging, or in the same report acknowledging, that India had a very, very serious health crisis.
So I'm going to stop you here, because you raised a very valuable point about, whether healthcare or even access to treatment is a public good or not. So Gopal, right at the peak of the pandemic, right at the beginning of the pandemic, I remember there was a big cheer among all of us activists who had worked on AIDS and public health, that for the first time governments came out and said that, vaccines and medicines and diagnostics would be public goods. Did that happen?
I think it was around the first week of April when WHO launched its Access to COVID Tools Accelerator and platform, as well as an initiative to develop all the new tools required for responding to COVID crisis. French president declared during the launch saying, when the vaccine comes out, it will be a global public good. So that created so much hype and hope among activists and everybody that, oh, this is the dream which we all work now going to come true through the COVID vaccine. But within a month's time, when the World Health Assembly resolution was under negotiation, that time itself, developed countries started arguing that it's the vaccination will be the global public good. Actually, there is a resolution on COVID, WHO resolution, basically declare vaccination as a global public good, but not the vaccine. Then within a few months, months later, when the data started coming in, developed countries all started hoarding vaccines. Even Canada at one point of time booked vaccines to vaccinate 10 times of their population, while many of the African countries or LMICs were still struggling to get what the WHO developed, something called 20% of the population, prioritized population to be vaccinated. So they were still struggling to even to even find out where they can source that vaccine. So this was the situation from, from a public good, it started moving to something called equitable access. But the idea of public good, vaccine as a public good, captured the imagination of many people, including the civil society, the initiative called People Vaccine Alliance and all started coming in. And recently, just before the negotiations started on the UN political declaration on pandemic preparedness and response, the independent panel on pandemic response made a recommendation to all the UN members to declare pandemic-related products and services as a global public good. But now, nobody is talking about to make it as a global public good, but I think irrespective of that jargon, we can still do a few things to realize that dream. The first thing I would say, the legally what we can do, legally, of course we can declare, but nothing will happen, but there are two international agreements under negotiation currently. One is a new pandemic treaty, and second is an existing treaty called, legal instrument called International Health Regulation. They are under, there are certain amendments. So one of the important demands from many developing countries as well as civil society is to declare all the publicly funded technologies to be transferred for the diversification of the production. So as we know, the vaccines are in COVID, even outside the COVID context, it's all developed through the public funding. So normally whenever the technology transfer issues comes up, developed countries normally say, oh, it's all privately owned. But there is no privately owned when it comes to vaccine. It's all public funded. And so therefore it's important to have such concrete deliverable provisions in that agreement. And the second one is politically. Politically what we can do, it's more public funding in this area. So here what is, it's not a rocket science. Cuba developed vaccines. Say, by the way, I am not a card holder of any communist party, but still want to put it on record. There are four vaccines that, two are as a candidate and two they approved. And what's the cost of these vaccines? And Cuba vaccinated their population using their own homegrown, homely developed vaccine, 50 million. That's all. They developed $50 million, okay? While developed countries spend more, far more than that, amount to
pharma companies.
And lastly, I would say that technology also offers to make it as a public good. I'll just take a 40 seconds and stop it. Whenever you copy a medicine, normal medicine like a paracetamol, you don't have to prove any safety and efficacy of that product by the company who copy it. Like that's why Bangladesh or Indian companies could develop all the COVID medicines within 3 or 4 weeks of the global announcement that okay, this medicine is there. They could able to develop these medicines. But when it comes to vaccine, it's not happening. Why they say that, oh, there is a know-how issue, there is a technological issue. It is not about technology. It is not about know-how. These companies possess these technologies and they can develop it. But the problem is the intellectual property rights called trade secret. Because the regulatory, everybody says that it is couched in the science, saying that regulatory requirement is that whoever produces this vaccine, which is copied from somebody else, has to prove the safety and efficacy through clinical trial. So that takes a lot of time and a lot of resources. You are basically reinventing the wheel. This can be curtailed through the technology. So the technology has developed in such a way that you can, many of the safety and efficacy concerns can be removed. So therefore, it is important that using the evidence from the latest science and technology, you can develop vaccines much more, shorter time and much more with something called a generic vaccine can be developed. There are possibilities. The last sentence is that, normally a vaccine takes 10 years to 12 years to develop. What happened in the COVID? 9 months, you started vaccination. So, but still people can argue that, okay, it's on emergency use license, etc. But what I am trying to convey is that there are certain lessons learned from vaccination and development of vaccine, so that basically challenge the certain regulatory assumptions behind the vaccine approval. So we need to look at those evidence and to apply in the non-COVID context, and we can achieve much more equity and justice and to realize vaccine or other biologics as a global public good. Thank you.
Yeah. Thank you, Gopa. Actually, this is something that a lot of countries are now thinking about developing the technology and delivering many more medical goods than they were reliant on others. So Gideon, coming to you, all of us have worked on all the different aspects of healthcare. Now coming to the fact that, a lot of resources that the TB program and the HIV program had built, human resources, but also diagnostic capacities that were utilized to actually start the COVID response. So what happened to the programs themselves, to the HIV and TB programs? How did COVID impact those programs?
Thanks, Lena. I think there has been no patient movement by far that is as well organized or as effective, well organized as the HIV movement. And this has happened over a long period of time. And as Farhad spoke in her opening remarks, I think, this is something which the global community actually recognizes in terms of patient movement. There are other patient groups, but there are nothing which is as well organized. The cancer patients, for example, are not as well organized as the HIV groups, which are also supported by different academicians or civil society groups and other groups, including MSF or other groups who are not in this room. We had a structure which was in existence when COVID came. We also had infrastructure which were meant for tuberculosis, HIV, or viral hepatitis when COVID came. We heard something which was always what we said, RT-PCR, RT-PCR, RT-PCR. We had those for HIV program. It's the same machine that we use, and we heard about GeneXpert, we heard about TrueNat. It's the same technology, it's the same machine where we use a cartridge different for different infection to diagnose that infection. There are different platforms. Some are from others. There are Indian homegrown machines. Now, these were all funded primarily by the Global Fund and in existence and running in programs. We did not have additional time or financial resources to bring in immediately to counter a COVID-related diagnosis. So what we did in most of the cases was utilizing the same machine that we had later on. We can come to the existing, to how things have evolved in terms of diagnostics related strengthening in the labs that we can come later on as a part of this. But we had all of those machines that were in the TB program, in the HIV program, and viral hepatitis programs. The government, and this is not only for India, across, and those were mainly funded by the Global Fund. So all the low and middle income countries had to, in large extent, programs that were already funded and were buying all these machines. For example, Indonesia uses these machines, which we call as a cartridge-based nucleic acid testing technology that we also know as GeneXpert. I don't use brand names most of the times, but that's the technology behind. And they use that machine extensively for HIV and viral hepatitis diagnosis. So they use that across for diagnosis of COVID. And that negatively impacted the uptake or the requirement for viral load testing for the HIV patients, or for RNA confirmation of hepatitis C, or for DNA confirmation for hepatitis B patients, based on which the treatment is recommended. So in one large way, COVID, the requirements for COVID, and understandably had impacted very negatively initially on the programs that were using this machine, because that was the platform was used across. The other positive part was not to talk only about the diagnostics, but also the use of what has always been internationally recognized. For example, if you open any of the WHO guidance, Control F, look for the word integration. Look for WHO CRO's Regional Integrated Plan for Viral Hepatitis, HIV, and STIs. Look for triple elimination of mother-to-child transmission of HIV, hepatitis B, and syphilis. And just look for the word integration. It's across, it's everywhere. But in actual implementation, it's really challenging. Ministry of Health officials often stands up to say that, look, it's very easy to put this in guidelines, but in terms of actual implementation, it's very difficult. But the patients group responded. Integration also talks about integrating the strategies within the program, including decentralization, including simplification, including the use of the peer workforce. And I think that was very, very positively used in responding to COVID. And the PL-HIV groups and the civil society groups are working on HIV played a very pivotal role in ensuring that all the people who were on treatment for HIV, if not all, most, or people who were on treatment for hepatitis C continue to receive their treatment and the diagnosis requirements. I'll stop it here.
Thank you so much, Gideon. I think very few people know that actually the COVID response was built on the HIV and TB response and viral hepatitis response. So I'm going to give last 30 seconds. I'm conscious of time and I want to open the floor to questions. So Brynel, you are in Maharashtra. Do you see people influencing how governments are behaving towards healthcare now? Is it moving towards what we would call, people are understanding that this is a public good that governments must deliver? So what's your thinking?
Maharashtra was very, very badly affected by the COVID pandemic, both in the first wave and in the second wave. And the government of Maharashtra, had put in a lot of measures, again, in response to outrage by civil society, by people who were directly affected by the pandemic. Social media was used in a big way, and also in many ways the opposition also played its role. Because of this pressure, the government acted firmly and on many fronts. One is in terms of expanding access to the social insurance program like the Mahatma Jyotiba Jan Arogya Yojana, which was made accessible for both COVID and non-COVID care. And even for people, there was no ceiling. So even people with the so-called white ration cards, those with incomes above 1 lakh, also had access. Then there was test prices were reduced, ambulance rates were slashed, the private sector was kind of taken over. Almost 80% of the beds in the private sector were taken over both for COVID and non-COVID care. So the room, room rents, consumables, everything was drugs, everything was fixed. And a lot of this came about, again, as you said, and through civil society engagement. Two important players in the civil society engagement was the Jan Swasthya Abhiyan Mumbai and the Jan Arogya Andolan, which also joined hands with this Corona Ekal, the movement, to basically take the entire issue of price rise, profiteering in the state. Now, so while the government acted at that point in time, we see that this momentum hasn't really carried forward to the post-COVID pandemic, because the I mean, funding, if you look at funding since 2021, 2022, the financial years, and even the most recent one, funding for public health in Maharashtra has actually either been stagnating or declining. So so while the government acted at that point in time, it's not sufficient only to act in relation to a pandemic. One really needs to take forward, transformative work within the healthcare sector beyond pandemics. Otherwise, we are constantly responding to crisis. Maharashtra is a rich state compared to many other states, but only, in terms of its gross state domestic produce, 0.7% of the state's gross domestic produce is allocated towards healthcare, which is much less than even what the national average is. So there is a lot more that the government can do in terms of strengthening both the public healthcare system, rural and urban, because it's in quite a crisis. Recently in Kalwa, just 60 kilometers away from Bombay, you must have heard a report of almost 18 deaths in a civil hospital over 24 hours. So this is the kind of neglect. Now, with out-of-pocket expenditure being very, very high, almost 48% of the state's expenditure on health comes from out-of-pocket, which tells you how privatized healthcare is in the state, and it's a major issue in terms of health equity. There are a number of schemes that the government is now, putting forward. The elections are up next year, so maybe it's also, one way. I mean, health today for COVID and many, in that sense has been a kind of a blessing, where healthcare is now on the agenda. But the government needs to back it up with adequate funding for healthcare and regulation of the private sector.
Yeah, thanks, Brunel. A lot of us in the health movement, in the people's health movement in India, have advocated for greater budgetary spends from the central and state governments. And I think this is something that if you want to find out more about the people's health movement, please reach out to Brunel. We've been at it, I think, for decades. So, Gopal, everyone's talking about local production, regional production. India's done that, been there. The Africa Union is looking at models of Egypt, India, Bangladesh, and other countries who produce. So what's the way forward for India? Is India dismantling its capacity? What's the trend?
I would say, as Sainath, towards the end of his talk, mentioned about India's claim. That's actually a big branding also used, pharmacy of the world. So this pharmacy of the world actually, if you look at it, it's all driven by the private sector and these private sector, but it's not the, something like the entrepreneurial spirit which resulted in this creation. The government played a major role. One of the important policy decision and legal decision which led to this was the Patents Act of 1970, which basically gave the freedom of operation for Indian companies to bring any medicine without any fear of patent protection or patent litigations, etc. But now we have introduced Patents Act, product patents back as a result of the TRIPS agreement, and now 18 years down the line. So what is happening right now? Our companies have all technological capacities to develop any medicines, to make the generic medicines, but they are not legally allowed to introduce that product in the market because they will face the patent infringement suit. So as a result of this, now I'll give you 3 examples. Like, these are like not a big disease in terms of numbers, like spinal SMA patients, spinal muscular atrophy, or cystic fibrosis. medicines are available. These are small molecules. Indian companies can bring it in 8 to 9 months in the market. So SMA medicine, risdiplam, is under patent in India. The cost for treatment will be 72 lakhs if you buy the originator medicine. Cystic fibrosis medicine, the cost of medicine will be 3,20,000 US dollars per annum. This medicine can be bring it for a per annum treatment around 5 lakhs rupees if it's a generic medicine is available. But we are not able to bring it. Then take a breast cancer treatment. It's one of the important, I think second in the terms of cancer burden. The medicines price, there are metastatic breast cancer medicines prices are like 63,000, 75, around 90,000 per month. Who can afford this? These medicines can be bring it. So in India, if there is no patent. So the COVID has shown one most important thing is that all the time the developed countries, especially US, told not to use compulsory license. Patent is very important and started categorizing countries into various categories and threatening with sanctions. So what did US did? To facilitate the Moderna vaccine and many other vaccine production, they have issued around thousands of patents they broke actually. There are on record 63 government contracts examined by one of the organizations shown that around 58 contracts gave compulsory license to companies to make use of it, okay? So where we are, please recall a submission at the peak of 2021 by the government of India, affidavit to the Supreme Court. There was a huge demand, even the court also hinted to the possibilities of using compulsory license. The affidavit basically said that there might be repercussions, diplomatic consequences of using compulsory license. But what US did it, even Germany amended its law, even Israel issued compulsory licenses. So what I would say is that, we should follow, as Eric Reynald told, we should follow what exactly US do instead of what US asking us to do, right? We should do what exactly US did. So we should do that. And secondly, the India is currently under pressure from UK, European Union, etc., to reduce the trips, our flexibilities in the public interest flexibilities or safeguards in our Patents Act. Okay, we should say no to that. And these are the two things we should do to maintain the production here. And we should not, the people of India should not be victims of the success in our pharmaceutical industry, because I am just 1 second, 1.5 seconds, I'll stop it. So if you take the top companies of Indian companies, majority of their revenue coming from US and Europe. So these companies can continue their business model, but that basically means they don't use a compulsory license, they don't break the patents to bring a medicine to the people of India. So this can be done only by a mid-level and small companies, their market is still in India. And government of India needs to recognize this fact and give a political and legal enabling environment for those companies to make use of it, instead of dictated by the big companies, because their revenue is anyway coming from elsewhere. So they don't want to disturb the big brothers and rub their shoulder in a wrong way, right? So we need to look at our own people's health and make use of the flexibilities in our Patents Act.
Yeah. Thank you so much, Gopal. At the peak of the pandemic, when MSF was trying to procure the vaccine, as part of the humanitarian buffer, big pharma corporations asked us to sign indemnity clauses and non-disclosure agreements and held us to ransom, and we were not able to buy those vaccines. So yes, we need more diversity of production, particularly from middle-income and low-income countries. So Gitin, coming to you on the last word on it, did we gain anything from COVID in terms of infrastructure and other resources, and can we just sort of repurpose them? Yeah, and is it the right moment as activists to start doing that, asking?
Thanks. We're short of time, and so we're very, very short. We gain a lot. COVID brought many bad things. COVID brought a lot of good things. Check in every district hospital that you have, you will have a TrueNAT machine now, which was never there before COVID. But has it actually increased in terms of viral load access for HIV patients? Has it increased finding hepatitis C patients? Has it increased in finding hepatitis B patients? We don't even know that, right? So it has good thing. How do we utilize this strengthened infrastructure to build on our public health system is something that is number one, that is unclear. We have 2.4 in India, million people living with HIV. You have 8 million people living with hepatitis C. You have 40 million people living with hepatitis B in this country. Almost nothing outside of the birth dose vaccination that is provided to newborn kids as a part of your infant immunization program, practically. The national program, which is called National Viral Hepatitis Program, hasn't really addressed those things. There are many details on hepatitis B. Anybody is interested, I can talk after this. Second, we picked up very important things. One is called differentiated service delivery. So now patients have to go in every month to your designated hospital to pick their medicines every single month. For other tests also you have to go in. This was changed in multiple countries during COVID. Are we following up on that and allowing patients to take multi-month medication so that they don't have to come in? Somebody has been compliant for 20 years on ARV, yet you still insist that that person comes in every single month. I mean, there has to be, and we adopted that policy, or to an extent implementation as a strategy during COVID. Are we following up on that? Not very actively. Decentralization, because the requirement was so much, with that, we decentralized it. That was proven to be a boon for patients because they don't have to keep on going to that and keep on waiting. Have we actually decentralized that testing portion? We really haven't picked up after COVID. So infrastructure, manpower, strategies, we have gained much in terms of implementation and policies and availability of assets, but haven't really gone through and then pushed through it.
Yeah. So what we need is some strategy, and I'm now going to open the floor, and Tamam, and there's another 2 hands over there. So Tamam, starting with you, and Shobha here. So 1, 2, 3, 4. Yeah.
Thank you. Thank you very much. And my name is Tamam, and I worked with MSF and the Red Cross for the past 20 years in humanitarian medicine. What I would like to ask is, we have seen a lot of the activism trying to adjust the mechanisms that exist, from the TRIPS agreement and its flexibilities to legal frameworks in countries. It doesn't seem to work. There seems to be a trap in everything that claims to be a governance mechanism that allows people to have more access. The trap is either within, embedded in it, or is the behavior, as mentioned, the pressure, for example, of the United States or European countries on patent relaxation in WTO or so on. There's always multiple backups. And today, Mr. Sainath mentioned 2 words that rarely get mentioned in an MSF event. He said crisis capitalism and neoliberalism, 2 of the things that are controlling the way we see the world, the way we navigate it, there's a commodification of medicines, and hence a commodification of the lives of people that we're trying to serve. And my question is, did any of us expect the mechanisms of availability in COVID vaccines to actually work? Did we think that COVAX will work? Did we think that any of those things would work? And if we thought so and they failed, is there another way for us to widen the range? Here, I'm not saying we shouldn't use the mechanisms that exist. We should, and we should do it aggressively and learn the lessons. But is there a way for civil society to widen the range of pressures so we're not consumed in fighting every little battle? MSF spent 2 years dealing with the WTO obvious, obstructionism. I don't know if we thought we'd defeat them, but is there something else that should be done so we are not continuing to be grinded in the same cycle? Yeah. Thank you.
So I'm going to take a very quick moment to answer that, because it's a generic comment that Tamam has made, and I just wanted to simply highlight that we need to continue to look at supporting organizations like the Delhi Network of Positive People, Third World Network, and the People's Health Movement. These organizations have been under threat for a number of reasons across the world. And these organizations work with people and governments to change the status quo. And I think this is one thing really very important. And second, no battles are won without people on the streets. And this is why I think the major difference between HIV and COVID was that we marched with people like Loon when we were asking and demanding ARVs. In COVID, we were locked up in our houses and not allowed access to the policymakers' corridors. So we had no way of talking to governments while they were negotiating at the WTO. So I just think there are massive differences in the way we mobilize, not just on social media, but as people on streets and of course demand our rights, something that maybe perhaps not something that MSF does proactively, but nevertheless. So there's a question at the back.
My name is Ridhima Sodi. I'm a health economist, and I've been working in the TB space for a few years now. And it's not necessarily a question, but I just wanted to add to the conversation that what I observed in the last three and a half years, in fact, I started working in TB when COVID has just started, was that a lot of diagnostics space was going towards COVID instead of tuberculosis. And for the first time in, I think, 2 decades or so, that the number of TB patients actually increased. And India accounts for 36% of TB deaths, patients who do not have HIV as well as TB. So, and 28% of the number of people who are in fact infected with the disease. What we saw in the field was that a case of what I am calling right now as confused diagnostics, wherein a patient goes to a hospital or a primary healthcare center and is somehow diagnosed as a COVID positive patient, admitted, or vice versa, or, and 2 months down the line, they realize they have tuberculosis. And, it's, I do agree with something which P. Sainath sir said about data and delusions, because in the quest of reducing or eliminating tuberculosis from the country, we are sort of, I wouldn't say making up numbers, but we are forcing on, improved outcomes, improved notifications. So what I see personally as someone who's a researcher, but also works very closely with the practitioners for that space, is that we suffered a lot. And of course, there are positives to be made out of the situation. But we, as people who are working for TB programs, did suffer a lot. And it was, in fact, the people on the field who were in the middle of the lockdown, going to patients' houses to support them with their medication, so on and so forth. And I'm sorry, I think I took a little bit longer, but that's all.
No, thank you, Ridhima, for your intervention. I think we are
wrapping up
at
the moment. Thank you very much for a very engaging discussion.
So everyone,
Yes, please.
I just wanted to say that please feel free to have conversations with us. By no means are we the experts on it. We just started the dialogue. We are open to being contacted. I work for the Access Campaign with Médecins Sans Frontières. KM Kumar works with Third World Network. And of course, we have Gitain from AMFA. And we have Brynel from the People's Health Movement and TIS. And of course, we have Delhi Network of Positive People and other civil society in the room. So feel free to contact us. And thank you very much to
AMFA,
AMFA,
everyone.
People's Health Movement, and the Third World Network. Thank you.
Thank you, everyone.